Welcome to the second table of this meeting. We have changed the order and the speakers from the previous table. We have added Dr. Rodriguez Palomares. He's going to talk the first place. And please, Dr. Palomares is going to talk about multimodality imaging in thoracic aorta pathology. Thank you.
Thank you, Sergi, for the introduction, and thank you, Dr. Alonso, for the invitation to participate in this meeting. So in the next minutes, I'm going to talk about the measurement and the evaluation of patients with aortic diseases. And first of all, when I'm talking about multimodality, the first thing that we have to say that what we need is to have a standardization in aortic nomenclature and measurement. We know that when we are dealing with patients with an aortic disease, we are managing the patient based on the diameter of the aorta. So this is very important to be very consistent in the measurement of the diameter and also to know exactly which convention and which kind of measurement or the way of measurement that we are doing. So that's why very important that we, in our guidelines, what we established is that it is very important to recommend that all aortic diameters should be measured in a specified anatomical landmarks and to use the larger diameter of the aorta. We know that the aorta is divided in different anatomic regions, that these anatomic regions are subdivided in different segments, and we have to refer the diameter in a specific area and in a specific segment when we are talking about one diameter. Another important point is that when we are trying to say that there is an increase in the aortic diameter, we should use the same imaging modality with a combination or a comparison in between these two measurements side by side in order to make sure that the patient has an aortic diameter, an increase in the aortic diameter. And finally, it's very important when we are dealing with patients with aortic diseases is that we should use the diameter, but also it's very important to divide or to combine the diameter with the body surface area, to use nomograms to know the normal population, and also to use the zeta scores as well. Not only for the whole population, but especially for people who are in the lower limits in the body surface area, because they are very important people, because lower diameters could have an impact in the prognosis of the patient. So another important point, once we know that we have to measure the aorta at different levels and we know the specific segments and regions, it's important to know that transthoracic echocardiography or duplex ultrasound, it's going to be the first imaging modality in the evaluation of patients with aortic diseases, not only the thoracic and also the abdominal aorta. It's very important to know that with echo, we can evaluate the aortic root, as you can see here, the ascending aorta, the aortic arch, the thoracic descending aorta, and of course, the abdominal aorta. But very important to know two different aspects. The first one is that by echo, we have what we call the blind spot in the aorta. That means that because of the trachea, we cannot evaluate the distal part of the ascending aorta and the proximal aortic arch. That means a defect around 4 centimeters. And also important to know that for the evaluation of the aortic arch and the proximal descending aorta, we can see that there is a dilation of the aorta, but we cannot say exactly the diameter because we are not extremely accurate for the measurements of the aorta at this level. So that in those cases, we need to be complementary or to implement also the evaluation of the aorta with CMR or CT. When are we using CMR or CT in patients with aortic diseases? So this is based, I will talk about that later, so we will use based on the availability of the technique in your center. It will be based also in the experience that you have in the center, but generally what we use is CT. We usually use it in an acute phase because we need a fast imaging modality for the evaluation of the patient with a global evaluation, and also for non-acute cases, for chronic cases where we need follow-up and chronic follow-up, we try to use an imaging technique that could be CMR because there is no radiation involved in this imaging modality, and that's why it is preferred, if possible, for the follow-up of patients with chronic aortic diseases. Once we have established the measurement that we want to evaluate, maybe it could be echo, maybe it could be CMR, maybe it could be CT, the first question that we should set in our minds is how do we want to measure the aorta? Should we use synchronization? It's not necessary to use cardiac synchronization, and the answer is that we need synchronization for the aorta, especially for the aortic root. You have images here where you can see the aortic root by CT with a non-EKG gated ECT. Also, you can see the aorta with a non-gated CMR on the image in the bottom on the right, and you can see that there is no good delimitation of the sinuses of Valsalva. So when we try to use an triggered image, and you can see the CMR, how the definition is when we are using a triggered imaging for the evaluation of the aortic root. Another important question is, should we use or should we do our measurements in diastole or systole? So that's an important question as well. We know that longer diameters are expected when we are doing our measurements in systole, but we have more artifacts because of the mobility of the pulsion of the heart. So it is recommended to use the measurements in diastole because we have less artifacts, and also because we don't have, as you can see here, an increase because of the pulsation of the heart. We don't have artifacts that could impact in the misevaluation of the aortic diameters. Another important point is that based on the different modalities, we can do our measurements in an axial, in a coronal, in a double oblique modality, and it is recommended that we have to use the double oblique modality because, as you can see here in the graphs, you can see that when we are using axial images, so we are increasing or we are overestimating the aortic diameters compared what we are doing when we are doing the double oblique technique. And this is also very important for the abdominal aorta as well, because there is elongation sometimes in the descending thoracic aorta or the abdominal aorta, and we know that when we are using the double oblique modalities, we are doing a precise measurement of the aorta. Another important point is when we are comparing echo, CMR, CT, it's important to know that we have like different conventions and different modalities that we can measure the leading edge to leading edge, the outer edge to outer edge, or the inner to inner. And it is important to know that using different imaging modalities, we have different sizes or different thickness of the aortic wall. Echo, because of the reverberation of the echo and also the shadowing of the echo, as you can see here, the aorta wall thickness is much higher compared to CMR and CT, and that's why when we are comparing MR, CT, and echo, it is preferred to use the inner to inner convention in CMR or CT, and the leading edge to leading edge in echo when we are evaluating the ascending or the proximal descending thoracic aorta. In the abdominal aorta, it is recommended to use the outer edge to outer edge because of the atherosclerotic plaque and thrombus that is more frequent in the abdominal aorta compared to other parts of the aorta. And finally, when we are evaluating the aortic root, it's important to know that we have like different modalities. We can measure the cusp to commissure measurement diameter, as you can see here, or we can evaluate the cusp to cusp measurement as well. So we know that we have a better diameter where we are comparing the cusp to cusp diameter because the diameters are longer compared to the cusp to commissure. And especially in patients like genetic patients or patients with bicuspid aortic valve, that they have more than 50% of asymmetry in the aortic root. So in those cases, especially in asymmetric ones, the cusp to cusp is the more important convention that we should use. Also very important to know that when we are doing echo and the variability that we have in echo and mostly in the ascending aorta and the proximal descending aorta is that the variability it usually is lower than 2 millimeters. That's why the guidelines and the recommendation says that in the thoracic and proximal descending aorta, not for the abdominal aorta, that it's more than 5 millimeters per 6 months or 1 centimeter per year. So we have to consider a high-risk patient when the diameter increases more than 3 millimeters or equal to 3 millimeters per year. So that's why we put these recommendations in our guidelines as well. So transthoracic is going to be the recommended first imaging modality in the evaluation of patients with aortic diseases of the duplex ultrasound, that we should measure the leading to leading edge convention in echocardiography, the outer to outer when we are measuring the abdominal aorta, the inner to inner edge when we are doing the measurements in the aorta by CT or CMR. We recommend to use also the outer for the abdominal aorta as well. And the double oblique technique when we are evaluating the aortic diameters by CT or CMR. Also, as I mentioned, we put in the recommendations to use the EKG-gated CCT when we are evaluating patients with aortic diseases. And just finally, to finalize my presentation, I would say that when we are evaluating patients with complications, I explained at the beginning of my presentation the measurements and the modality, but going to the disease, when we are evaluating patients with an acute aortic syndrome, especially for aortic dissection, we will use CT. We can use CT for the evaluation of the patient because, as you can see here, we can evaluate the presence of entry tears, compression of the false lumen, also to see the visceral branches that are involved as well. But as I mentioned, depending on the expertise of the center, we can also have the same information when we are using a CMR. We can evaluate the presence of the entry tear, the presence of thrombosis. We can evaluate even, we have a dynamic, we can evaluate the flow as maybe Sergi explained before with CMR, so we have a more complete evaluation of the aorta when we are using CMR. I know that for surgeons, you prefer to plan the surgery more based on CT, but also some important information for the follow-up can be taken from the CMR. And when we are dealing with patients with problems of the aortic wall, so for example, in this intramural hematoma, that we can also evaluate this patient with a CT, especially in the acute phase, that you can see a hyper-enhanced image in the pre-contrast images. But the modality that we prefer to use when we want to evaluate the aortic wall, it's going to be CMR because we can evaluate, we can perform a tissue, we can evaluate the tissue characteristics of the aortic wall. For example, you can see here a patient with an intramural hematoma, and you can see the hyper-enhanced image in T21 weighted images that it's associated with a intramural hematoma in the acute setting. And here we have like a patient with 3 different pathologies, and because of the characteristics of the CMR, we can differentiate in between an intramural hematoma, a patient with aortic atherosclerosis, or a patient with an aortitis. And also for the evaluation of patients with aortic ulcers, we can do the same. We can evaluate those patients with a CT, and we can have the same information with CMR. So again, depending on the expertise and the possibility and the capabilities of your center. And finally, when we have a patient with a suspicion of an infection or an inflammatory aortic disease, so we recommend the use of PET-CT because we can have also the metabolic information of the aortic wall. Just to finalize, when we are dealing with a patient with a problem with an aortic disease, we have different algorithms. I put here the one that is in the new guidelines for thoracic aortic diseases. When, as you can see here, we usually start with the aortic diameter. We always perform a CMR or CT just to evaluate the global aorta and to make sure that the diameters of the aorta are very similar in CMR, CT, or echo. So that make us feel much sure that we are doing a good evaluation or follow-up of the patient by echocardiography. And then we have the other risk markers, and based on that, we have the different thresholds for surgery in this population. Just as a take-home messages, just to say that when we are evaluating a patient with an aortic disease, we have to use the appropriate imaging modality based on the expertise and the availability in your center. It's very important to have an expert in cardiovascular imaging to evaluate those patients, to have to compare the images, the same imaging modalities side by side to make sure that there is an increase in the aortic diameter. We have to describe which convention we are using because this is very important. Based on the different conventions, we can have different diameters, as I explained you before, and as again, when comparing, use the same imaging modality for the follow-up of the patients. Thank you very much for your attention.
Thank you, Dr. Rodriguez Palomares, and we are going to move to the talk from Omar Andres, CIDR maps for endovascular procedures.
Okay, it's me, for me, in the best moment of the day, at the end of the journey. I arrive to my home, I relax, I play with cider, I start to sizing, simultaneously watching television, a film, or a news. This is for me, this is my sport. At the end of the day, this is my hobby. So you can see we can do the work with cider from home. It's not necessary to stay in your office. So thank you very much to Cardiva and Dr. Alonso for inviting me. I'm going to talk about CIDR maps for endovascular procedures. We started with that technology many years ago. I don't have disclosures. Many years ago, and CIDR brings us a little screen. We put that in our surgical room. We connect that to internet and to our X-ray system. Our X-ray system was a CR portable CR, and we start about that. Then, with the time, with the year, weeks, months, CIDR systems learns about the fusion, learns because it's based in artificial intelligence technology. 2 years ago, we changed our surgical room to a better surgical room that you can see. We are very, very happy with CIDR, and we migrate the system to our new surgical room, and that's what that was a very good thing. I think for understand how works a CIDR system is important to see, or I show you based in a case. When you enter to the vault, you only need a password and an address, internet address. You enter with your password, and you have all the patients here. You can choose the patient. You can download the CT scan directly from the PACS of the hospital or from your computer. But you can connect from your home to the PACS of your hospital and download every CT scan study. When you have the CT scan, the download in your web page, you can see here, you start to work with that. The first that when you open the CT scan, the CIDR measures the volume of the aneurysm, as you can see. This is a new tool, very important. This is when you enter to the 3D dimension in the vault. For a start, you have to select first femorals, each femoral, 1 point, and another point in the suprarenal aorta. You can see the 3D dimension, and CIDR normally gives you a center lumen automatically. In that case, I have to do it manually because that case is with a graft inside. You can see it's an anaconda in the past of the years, migrates and make an aortic dilatation. And that's the reason for we can do the center lumen manually, as you can see now. When you have that, CIDR incorporates in another tool is very useful, is a sizing tool. You can do all the measurements, diameters, lengths, points you are interested in the anatomy, you can mark that. You can do all the measurements like another software of we are like Osiris or like another Endosize or another software that you know. You can do that in the vault of the case. You can move that. You can put the names of all the things, of all the measurements, to know about that. Then you can add a vessel if you want, a new vessels, and put the rings where you want in the vessel arteries, of course. And if you want to select a point of the anatomy you are interested, you can do that. It's important I like the ring in the hypogastric because it's a different with the other softwares are very exactly the hypogastric. This is the folder of the patient. You can see the folder of the patient, you have the map, and if you want, in that folder, you can add everything that you want. For example, I added here the sign of the prosthesis, the measurements. You can add all the things that you can see now. This is the design, and you put that into the internet vault in the folder of the patient. Not only the design, you can put the measurements of the company. You can put a tag of the case to classify all the patients. You can put a tag. And you have here the mark. If you want to, you can import another CT scan. And you can enter if you want to put another ring or make anything else. This is in the surgical room. Now, we have a remote control. We have to select the patient. We have all the thigh done. And we work with that remote control. We put in the table. And then we can work while we are doing the operation. In the operation, okay? You can see now the reconstruction, the work that we done is that, and now you can see how it works in the case. This is the case. When you start to do X-ray, the first that you can see is the map of the aorta in the screen. You can see now. And if you want, you can modify the center lumen to put, because the straight guide wires sometimes modify it a little bit the anatomy. For example, you can see now the rings, but not the aorta. We can select that if, for example, if we are not comfortable with the draw of the aorta, we can eliminate for a moment and only work with the rings. You can see the rings. It's very important here we cannot see the rings. This is the reason, because it's important to see two vertebrae bones for SIDAR works, because this is a very heavy projection, lateral 90 degrees projection, and we cannot see. Now we can see because we have vertebrae, and the SIDAR system detect the vertebra, send the image to the internet, to the vault, and then internet return the image and the fusion technique. This is the left renal treatment. You can see now exactly the ring with the stent. And then the last is the right renal. Okay, sometimes could be, you can see this, the right renal with the anatomy is very heavy, and you modify it with straight guide wires. Sometimes could be not very exactly, but you can modify that if you want. Okay, that's final result. It's important. You can see the hypogastric. The hypogastric don't move if you want. It's important. It's not like a mask. You can modify parts of the anatomy of the patient, not all the anatomy. At the end of the you can see now the surgery. At the end of the case, in internet, in your web page, in the folder of the patient, you have recorded automatically all the case. If you stay 1 hour, you stay 2 hours, all the case will be recorded. And if you want, you can download all the video. In a 4MPG system, you can see, I can see directly from the internet. I can make screenshots and make pictures for doing after like now presentations or anything that you want. You can put the name and and to save in your computer. You have here the picture and the video, all recorded. And then if you want to edit, to make an edition, is very useful for you. This is the video, and we can edit. We enter again in the vault. You can see now here in the vault are the video and are the screenshots. If you want to make a lot of screenshots, no, it's no problem. You can see now if you want to record files like the sizing of the company or anything else, you can put it in the vault, and it is here in the vault for all the time. For all the time, you can then 1 year later if you want to go to enter again to the patients, you can modify it. You have a help tool to contact with CIDR people. Okay, and for conclusion, I think it's obviously in that software of 3D fusion. No, it's obviously the shorter producer time, and obviously too reduction in radiation exposure and in contrast agent. And for me, an accuracy for me, in my opinion, I think this system is better than another fusion systems like Philips or like Siemens systems. It's my opinion. And for me, the more important is that you can review the system forces to you to review the case the day before the proceed, and when you arrive to the proceed the next day, you arrive with the case in your mind. And for me, this is very important. Thank you very much.
So it's been a very relaxing presentation, Dr. Andres. Thank you. We are going to move forward with the role of AI forecasting complications following endovascular aortic repair. Fabian Herrera.
Thank you, dear all. It's a real pleasure for me to present today. My name is Fabien Larrère. I'm the head of the Department of Vascular Surgery in Antibes, in the south of France. And I'll speak about the role of AI forecasting complication following EVAR. So artificial intelligence is a very broad domain that regroups 3 main fields. The first one, NLP, natural language processing, which is application for speech or written language. You also have robotic and innovative devices. And you have the field of the vision, which is the application for videos or images. Machine learning is a subdiscipline of artificial intelligence where you give the machine the ability to learn from data set, and deep learning is a subtype of machine learning where you give the machine a large quantity of raw data. That's what we call big data. And the main AI algorithm used are the artificial neural network, ANN, or CNN, convolutional neural network. And artificial intelligence brought new perspective in both medical research and clinical practice. We have to keep in mind that AI algorithms are fed with a large quantity of data, health data, which can come from the health record, electronic or manual. You also have physiological, biological, and for us, vascular surgeon, medical images from CT scan, MRI, or ultrasound. And now, with the increase of smartphone and other devices, you have access to digital data. So what are the applications of AI in aortic aneurysm in the different fields? A brief overview. So for the natural language processing, it can help, for example, for the automatic identification of patients with aortic aneurysm in medical records. Regarding the machine learning field, it can help to develop predictive model to propose for a patient a personalized therapeutic approach. And most importantly, in vascular surgery, in the field of the vision and all the CT scan and other imaging technique, it can help for the automatic detection and characterization of aneurysm, and this can help to improve screening, diagnosis, pre-surgical planning, and also follow-up. So let's have a closer look about regarding the use of machine learning algorithm and complication following EVAR. So our team and others developed several reviews on the topic, on the use of machine learning to predict outcomes following EVAR, but also aortic repair in general. So some authors, for example, developed AI algorithm to predict embolics. So for example, on the first study, they used the CT scan follow-up at 1 year, and they involved more than 100 patients. And they had a very good area under the curve to predict type 1 and type 2 embolics at 0.88. Another example on the second article, they had a look on type 2 embolic, and they developed a machine learning model on the follow-up at 6 months and 1 year, and again, a very good area under the curve to detect both embolic and aneurysm sac expansion at 0.96 and almost 0.9 at 1 year. Last example of the use of machine learning to detect outcomes following EVAR, which has been performed by a strong team in Canada, Ben Lee and Mohamed Al Omran. So they used the NSQIP, the National Surgical Quality Improvement Program, with more than 16,000 patients, and they trained 6 machine learning models to predict 30-day major adverse cardiovascular events. And they found that the machine learning model had a very good area under the curve at 0.95, and they perform better than the classical logistic regression, classical statistical analysis. And they also had a look at the big registry, the VQI, with more than 63,000 patients, and again they trained 6 machine learning models to predict 1 year mortality, and also a really nice area under the curve at 0.96. We can find many papers now in the literature. They use mostly as an input data imaging data. So we had a look on the machine learning model for the prediction, and now let's have a look at the second big field, the vision, and how we can help to enhance imaging analysis for EVAR. So our team were among pioneers to develop AI algorithm few years ago using a supervised deep learning model to develop software which can allow automatic detection and characteristic of AAA, but also automatic measurement of the vessel, because we know at the beginning all the commercialized software were semi-automatic and not completely automatic. But we were not the only one, and other team, mainly from France, with Stéphane Hollon and Eric Ducasse, developed their own convolutional neural network for an automatic measurement of the maximal AAA diameter, and they find a very good correlation with manual segmentation performed by human experts. AI can also be used for the pre-operative planning, and another startup from France, Predissurge, led by Jean-Noël Albertini, for example, designed some numerical simulation using AI to see the accuracy of the system for the planning position of fenestration, for example, during complex EVAR. AI algorithm has also been developed to detect post-operative complications based on CT scan, because we know that EVAR required a long-term surveillance to detect the complication. So some authors develop algorithm to detect aneurysm sac enlargement. So this is really nice to have an automatic segmentation for a fast and robust measure of the AAA volume without doing nothing manually. And other authors develop AI algorithm to improve the image quality, and this can help to reduce the noise intensity and artifact, and this can help to improve the detection of complication post-EVAR. And of course, several AI models have been developed using machine learning technique to detect endoleaks based on CT scan, but also now from non-contrast CT scan. And for example, on this study, they found a very good accuracy of the deep learning algorithm to detect endoleak based on non-contrast CT scan. I'll just finish saying that there are a lot of potential benefits of the application of AI after EVAR. We saw that it can help for the prognosis to develop predictive model. It can facilitate preoperative planning to help for the anatomic characterization. And mostly, it can also help to better detect post-operative complications during the follow-up. But we have to keep in mind that AI algorithm function like a black box concept, and it's extremely important to have external validation if we want to generalize all the result to other person with different socioeconomic or other characteristics. And we have to take into account that it can cost. There is a strong, especially in Europe, ethical and legal framework, and we have to educate both patient and health professional to AI before its implementation in daily clinical practice. Thank you.
Thank you, Dr. Leire. So the next talk would be about force technology, 3D device guidance without radiation, by Goran Lundberg.
So thank you very much for the kind invitation to come here and share our experience from close to a year of using the force technology. No disclosures related to this topic. So in modern vascular surgery, radiation exposure is a major concern, and perhaps especially so, or for sure especially so, in complex EVAR. And in a modern hospital, there is probably no other intervention coming close to the exposure in the operating room for the surgical team to those performing complex EVAR. And in these last or recent ESVS aortic guidelines, it is highlighted that simple radiation safety behavior in the OR, which is our responsibility, is key. But there are also new upcoming techniques where force fiber optic real shape is one and already in clinical use. And the first paper on its use in humans is from 2021 and from Utrecht in the Netherlands. They used it in 20 plus patients with abdominal peripheral aneurysms and some PAD patients. And this is an American study from 2023 where FEVAR and BVAR cases where they used force was compared to matched historic controls. And they found a 30 to 50% reduction in the force group as compared to the controls, relating to procedure time, fluoroscopy time, and total X-ray use. This is a study from this year, also American, which has very similar results. These are PMEG procedures and X-ray use and fluoroscopy time down by 35%. So this is the equipment. It's an add-on to the Philips Angiolab, and its parts are the black box, as we said, the LumiGuide engine, which produces and transmits light through a dedicated guide wire. And this guide wire is then, or light is reflected to the same box, analyzed and generating a 3D visualization of the entire length of the guide wire. Then there is this 3D hub, which is the connection to any standard angiography catheter that can be used in combination with the guide. So this is what it looks like. The 3D hub is connected to the catheter of choice. The guide wire, it's a little bit like Terumo glide wire, a little bit stiffer, but a bit similar. And then you register the catheter and the guide wire as part of setting up your fusion in the OR. And then this is what the screen looks like. Typically, there is this biplane look to it, where you have the right screen where you can choose any angle, which is a key feature of the technology. So you're not limited by the mobility of a traditional C-arm. And then you see the catheter in a color of choice and the guide wire. And in the OR, it's this LumiGuide engine, which is together with its docking top, where you connect the guide wire, which are the only physical changes. Then there is extra software, but that's inside the boxes and machines that are already there. So this is what it can look like, cannulating the right renal artery in a PMEG case, where you can have the CT fusion image as an overlay, as a map, or fluoroscopy alone, or DSA. And you need a short fluoroscopy and contrast to check the position and to check and to do the wire exchange. And this is a celiac trunk cannulation in a 4-Fen CMD. Again, this biplane feature is very useful. And you can fade in and fade out the fusion image background, and no X-ray. And then there are a few areas, perhaps less intuitively, where you can use the same technique as at the very start when you place your stiff guide wire in the ascending aorta. You can use LumiGuide for that as well. And you can freely move this background of fusion image, and you can rotate it if needed. And you can avoid the neck vessels and end up in the ascending aorta. Then, as we'll see, when you remove the guide wire, you can't see the catheter anymore, but it's still there. And then you need short fluoroscopy just to check the position and to do the wire exchange. And this is an example from the contralateral side, cannulating the fenestrated component using a reversed catheter. And you can again move your background to see a bit more of the guide wire and have better stability and hopefully enter the tube there. And likewise in cannulation of the contralateral gate in the fenestrated component or in an ordinary EVAR, if you want to. Again, very useful with these double angles without the need to move your C-arm. And there you enter. So this is the equipment we normally use. The limitation is the length of the force-specific guide wire. It's only in one length for the moment, so it limits the choice of catheters, which can be no longer than 100 centimeters. Steerable sheaths can be used as you're used to. And these are the cases we have used LumiGuide in so far, mainly FIVARs, a few BVARs, and IBDs. So what do we think about it? We feel that it's a valuable complement to fluoroscopy at, as I showed you, multiple steps. The biplane feature is especially useful, and fluoroscopy is still used, but much more just for a second or two instead of during longer periods. And I'll come back to how much it decreases X-ray use at our place. And we found it relatively easy just to start using. A word of caution on two cases with hemorrhage we have had during these first 40 patients minus. We don't know for sure the link to the LumiGuide wire because the bleedings were not immediately obvious. But if we look at the left renal artery here and the upper branch where the injury occurred, it's a very sharp angle and a plaque. And that anatomy can be challenging or is challenging to the LumiGuide wire as it works today. So we fixed that with a covered stent and have learned to stay a bit more proximal in the target vessels and do the exchange of wires there. So on the wish list is, and it's actually already here, but not quite for sale yet, a longer guide wire would be very helpful, and a softer guide wire tip, I think, is also on its way. Better torque. The torque is somewhat restricted because the back of the guide wire is fixed to the system. More dimensions might come. And this is what it looks like when we compare the year in light color to the next preceding years on total X-ray use expressed as DAP and fluoroscopy time. We have had a steady decline or decrease in X-ray use over the last 2 years, probably for several reasons, but it seems to have accelerated from this year when we have used LumiGuide. So we believe that it's in a great deal an effect of LumiGuide use. On procedure time, we haven't quite seen the same thing. A little bit longer this year, but if we look at comparable cases with LumiGuide, it looks like this. It's probably a learning curve. And these are the centers in Europe today that have LumiGuide. We are here and look a bit skeptical, but in fact, we're very happy to be among them. And thank you.
Thank you, Dr. Lundberg. We're going to move on to the talk Robotics in the Vascular and the Vascular Field, Current and Future Perspective by Colin Bicknell.
Thank you very much, and thank you very much for the invite to come to Oviedo again. It's a brilliant conference. I'm going to talk to you about robotics. These are my disclosures. So there are many potential advantages of robotic technology that you can think about. Firstly, increase in performance, being safer and faster and more effective, but also decreased radiation for the patient and operator, shortening learning curves, reducing back pain and long lead wearing times. It doesn't have to be painful doing these procedures. But also, perhaps we can advance the boundaries of care that we provide and future robotic applications, and perhaps telemedicine might come into mind when you think of these advantages. So this talk is about how far we think we've come with studying these advantages and what might lie in the future. There's a number of robotic systems that are or have been CE or FDA marked. This is the Hansen system, which is an electromagnetic system in the top left-hand side. It's a master-slave system. Bottom is stereotaxis, which is the magnetic one used in EP quite a lot. And Corindus and RoboCath, which both use existing catheters, robotically controlled from outside of the operating room or even in a different operating room. Our early studies in robotics, we started off looking at the Hansen system. As I said, it's a master-slave system. You sit outside of the operating theatre. You can take your lead off, have your lunch, and control the robot control manipulator that sits above the patient's feet, and that controls a catheter in that top left-hand panel, which is inside the patient. And we started off with some benchtop models. And using those benchtop models, we were able to manipulate this catheter here, this is what it looks like, with an outer sheath which ends about at that white tip there, which can go left and right, and an inner, smaller 6 French leader catheter with a guide wire control as well. And we showed in the model studies that actually it really was more accurate in cannulation of vessels. It seemed to be responsive and accurate, even if there was tortuous anatomy, and it was a particularly stable system. So once you get into position, you can take out that leader catheter and the sheath won't move. These are some of the examples that we had using this is a silicon model with pulsatile flow. These are experienced operators for the whole procedure, time and movements, and every single person decreased the number of time and movements they took to get in those 4 fenestrations, the task that we set them. We mapped the path length, so we took the tip of the catheter and we followed it over time until the tip of the catheter got into the carotid artery on the top here, or into one of it was the right renal fenestration, this, in conventional and robotic systems. You can see the red maps the path length of an experienced operator doing getting into one of the fenestrations, the green, the same operator, but with the robotic catheter. The number of movements and path lengths is significantly reduced. But you're never going to sell systems based on an anatomical model. And in fact, if you look at the Da Vinci system, it's a good example. There were enthusiasts, but it didn't really take off until the urologist proves that you could avoid the neurovascular bundle much more effectively with a robotic system. There was a clinical benefit to using robotics, and now I think most centres have urological robotic systems. So we looked in patients. This was our experience. This is a group of different patients. It was 116 patients in 150 targets. So it spread over about 5 years, a few years ago. The numbers don't mean an awful lot because they're completely different patients, of course, but we did have good technical success. We didn't go from robot to manual, except in a couple of cases, but we went from manual to robot conversions and used the robot in 16% of cases. And as we got more experience, we started using this robotic case when we had that particular adverse anatomy, and it became a very useful tool. We obviously progressed as we got more experience, but these are some of the cases using it to cannulate difficult contralateral limbs, embolize difficult, tortuous internal iliac arteries, and go through fenestrations for FEVAR. That was our favourite operation, is the FEVAR cannulation outside of the room. We got more complex and we went to carotid artery stenting and really fixing some of our endovascular disasters with our visceral hybrid grafts and trying to close false lumens and type B aortic dissections. So if you look inside, if you look at the clinical data that we got, we also showed our path length. It was significantly reduced in situations such as cannulation of the EVAR limb, contralateral limb, and also, perhaps more importantly, in those difficult fenestrated cases, getting into the renals, SMAs, and celiacs, the path length is dramatically reduced. More importantly for your health, your radiation exposure is dramatically reduced as well. So I've picked obviously the best one, but the superior mesenteric artery cannulation, where the C-arm is at a steep oblique angle. When you do it manually and cannulate it, you have a significant radiation dose. And when you stent it, you still have a significant radiation dose. When you look at cannulation robotically, you're sitting outside the room apart from one or two parts of the procedure. So there's hardly any radiation dose, and that stability of the robotic catheter meant that our stenting procedures were significantly reducing our radiation dose as well. We looked at crossing the arch, simply actually just putting a stiff guide wire in the aortic arch at the level of the aortic valve, manually and with robots, and with a robotic catheter. And because you've got that control, we think, and you can pass down the center line of the vessel, we were able to reduce the transcranial Doppler hits that we measured at the time. We thought one of the main benefits of the robotic catheter was, in fact, carotid artery stenting. You were able to, with it, navigate across the arch safely and into the common carotid artery. There was no need now to go past the lesion until you had a safe sheath in the common carotid artery, and from there you could then enact carotid artery stenting, and we had a series of 14 of these without any neurological sequelae. So that system, though, was withdrawn a few years ago, and it was withdrawn from vascular surgery, and because of probably the reason is a financial one. It was very astute to take it to the bronchoscopy world, to look down the airways where it's doing very, very well, the same robotic catheter. It was very expensive, this catheter, and there was a significant cost to the institution, perhaps with cheaper alternatives and steerable catheters now. It was only a catheter to deliver existing therapy. So it really was just getting you to the place to deliver the therapy, which may have been one of its downfalls. Really, the procedures were limited by the same thing that the manual procedures are limited. Probably imaging is the most important one. So in the future, if we're going to realize the rest of the potential of robotics, there are a few things I think that we need. The first is investment, and the good news is that actually there is a huge amount of investment in robotics, both in medicine and in endovascular. You can see some very big numbers of 22 billion and billion, and even the NHS is paying for robotic surgery frameworks, which is a novelty. We need to be combining the expertise and knowledge in robotics to guide that catheter with different technologies to aid navigation. And perhaps I'm thinking really of aiding navigation with some of the technologies that we've already heard about, FORS and SIDART for sure, electromagnetic navigation as well. And also, if your catheter has specific markings, you can actually model it computationally quite effectively as well. So I think once imaging is combined with robotics, you may see that you can do an awful lot more a lot quicker. We looked at MRI as an already present 3D imaging system. I guess MRI also has the advantage that it could well then image the pathology and allow us perhaps to perform other procedures that we don't already do, because using the same blunt tools that we have to treat atherosclerotic disease with balloons and stents is probably not right, when we have the ability perhaps to operate telerobotically, perform the whole procedure robotically, and operate at a much smaller level. Imagine a situation where you can drive through the vascular tree without touching the side at any point and causing embolization. When you get to it, performing an endarterectomy from the inside or something like that you can't do conventionally at the moment. So there's a lot of robotics coming. that this is a market landscape scoped a couple of years ago, and it shows you the vast number of robots in development at the moment in the medical world, and I think it will come very much in endovascular. So I think the potential of robotics has been realised. I think we've shown in models and in humans that it's faster, safer, more reliable and remote from the patients, and others have done telemedicine procedures in different countries. But there's many barriers, of course, to implementation, and that's kind of halting the clinical development at the moment. There's a lot of potential, though, for automatic navigation, changing the way we treat disease and telemedicine. And there is investment and there is knowledge. So I think your jobs are safe, but the future is very bright. Thank you very much.
So thank you, Dr. Bignell. And our last talk would be about emerging biomarkers, improving diagnosis and predicting prognosis of aortic pathology by Fulvio Morel.
Oh, thanks so much for the invitation. I have to disclose that I'm not a surgeon, not a vascular specialist. I'm an emergency physician, so I'm quite an alien in this symposium, but I've come into aortic disease through acute aortic syndromes that we treat and encounter every day, or that we think to maybe treating and encountering every day in the emergency department. And this has led to interest both scientifically and clinic. So, of course, we all know that when an acute aortic syndrome occurs, I will focus on this part of aortic disease, several events are happening, and of course, one of the major is organ malperfusion and damage. So it's very important what happens into the vessel wall and into the organs, and this creates space for biomarker release into the bloodstream. We have a chance to apply these biomarkers to improve diagnosis of acute aortic syndromes. And of course, in the emergency department, we have the issue of selecting patients for CTA. This is not trivial, it's not easy for several reasons. And it's very evident in the results that have been published, but in everyday practice. Huge amount of initial misdiagnosis for acute aortic syndromes. When you try to estimate the number of patients that you miss, you can only try to make some good guess. But this is a very nice study made in the United States where you can estimate that about 4.5% of patients with an acute aortic syndrome are sent home after an emergency department visit. Of course, you have also a problem in yield in diagnostics of your CTA decision. If you look at studies, well, you can say that we are very good, but clinical studies do not match clinical practice. On your right side, you can see that in the United States, in Canada, the rate of positive CTA for suspected acute aortic syndrome is lower than 3%. But even in Europe and in most centers with CTA available 24/7, and especially if you're expert in aortic diseases, well, you will keep requesting CTAs that will turn out negative. So there's an issue in patient security, of course, and there's an issue in diagnostic flow. So we need biomarkers to help us. And we may apply biomarkers also for outcome prediction. Of course, mortality, organ damage, treatment, decisions for you, specialists in vascular treatment. First thing that happens in the vessel when you have a dissection, tearing, hematoma, ulceration, you get activation of the coagulation cascade, platelets and thrombus. First thing happening. And this goes on through time, of course, for patients that become subacute and chronic with partial thrombosis, sometimes complete thrombosis. So it's a dynamic process. And of course, the king in diagnostics of this process is the D-dimer, which is produced by plasmin on fibrin. You can detect it using different assays that you have in clinical practice, that we have everywhere in emergency departments, with very high accuracy and sensitivity. This is well known. This is the first seminal study by the IRED investigators in 2009, showing that you are in the thousands levels for D-dimer in acute aortic syndromes, especially in dissections. And we have now added several studies. This is the latest meta-analysis published right now on Annals of Emergency Medicine, with the main analysis on 18 studies. Several of them have patients from our group. And the summary estimate for sensitivity and specificity are 97% and 56% for diagnosis of acute aortic syndrome. Of course, with some few false negative cases of D-dimer in patients with acute aortic syndromes, especially associated with some intramural hematomas, short dissections, early presenters, late presenters, young age, and there may be an issue also with the Chinese ethnicity. Of course, there's a huge number of false positive cases, which is the limit of D-dimer. If you combine D-dimer with clinical stratification, the ADRIS score is the approved risk stratification in the guidelines, well, you further improve sensitivity to about 98%, specificity stays there. And if you add also at the bedside of the patient, an echographic evaluation, hopefully this should become the standard of care for patients in all emergency departments, well, you are potentially able to go almost to 100% sensitivity. And this has been done in a multi-center study. And so this is the reason why in the 2024 guidelines, there's a class 1 level B recommendation to use a multi-parametric algorithm, including D-dimer for diagnosis of acute aortic syndromes. There has been application of D-dimer also for prognostication of outcomes, and both in hospital D-dimer and admission D-dimer has been related to mortality in patients with acute aortic syndromes, with a huge difference between patients that keep having very high D-dimer during hospitalization. The predictive value of D-dimer for mortality in acute aortic dissection applies both to type A aortic dissection and type B aortic dissection, probably a little bit better for type E than for type B. And when you have coagulation, of course, you also have involvement of platelets. If you look at patients with acute aortic syndromes, well, then you have about 10 to 15% of patients with clinical thrombocytopenia, less than 100,000 platelets per microliter. And if you look at their MPV, PLT ratio, you tend to get an increase in this ratio in patients with acute aortic syndromes. So there's also a group of patients that will need support and that are at risk of hemorrhage. Has been noticed a relationship between what is going on, of course, inside the vessel and the platelet count and the MPV-PLT ratio. The bigger the volume and the bigger the activation and consumption of platelets. Also in patients with type B aortic dissection undergoing TEVR, this is a Chinese study, have a relationship between their platelet levels and outcomes, with lesser outcomes in patients with less than 150,000 platelets per microliter. The second thing that occurs in a vessel when you have dissection or acute aortic tearing, when you get inflammation locally, and this translates early into systemic inflammation. And there are a few studies on humans looking at inflammation. There are inflammasomes. Some are a little bit more aortic specific, NLRP3 inflammasome, AIM2 inflammasomes, leading to activation of interleukins and release of fire. There's fire burning in the aorta. You all know that if you apply PET-CT, you will see that you have deep captation and activation within the aorta, both in intramural hematomas and dissections. So there's huge inflammation, and this inflammation can be also caught using very rudimental things such as neutrophils and neutrophil lymphocyte ratios in the bloodstream. And actually, if you take a look at the accuracy of neutrophil to lymphocyte ratio, this is probably the best marker when you look at acute inflammation in acute aortic syndromes. And this is really specific to the acute phase, because patients that go into chronic or other groups of patients do not have this alteration in the ratio. Of course, inflammation means also C-reactive protein, and again, there's a relationship between tear volume and CRP and outcomes of patients. And in the intensive care area and in the medical area, there's also a relationship between the peak CRP in patients with type B aortic dissection and the way they breathe, the minimum PF ratio that goes down. This leading to, of course, an increased mortality in patients with persistently elevating CRP, both in the short term and in the long term. So having increased and persistent coagulation, inflammation, and platelet consumption predicts mortality and negative outcomes. Then, of course, there's the huge amount of organ malperfusion that you may have in patients with acute aortic syndromes, and the king of biomarkers in this area is troponin. This is a Chinese study in over 1,000 patients with acute aortic syndromes. Patients with positive troponin had 44% of death compared to 19% in patients with troponin negative, 2.6 about odds ratio. And in the study, there was a clear demonstration of an increase in prediction in the model when you incorporated troponin over clinical values alone. So a positive troponin does not necessarily mean that the patient has a myocardial ischemia or infarction. It means that it has myocardial damage. And myocardial damage may also depend from several reasons, not only coronary flow, of course. Even an old biomarker such as LDH has shown that, especially in medical patients treated with best medical treatment over 70 years of age, relatively stable in clinical terms, that you treat medically while deciding with the specialists on what to do next, maybe in the subacute or chronic phase. Well, if they start and they persistently have elevated LDH, well, they will do better, they will do worse. Then there's a huge amount of studies, some are more recent, others are less recent, on different markers coming from inflammation and coagulation and so forth. But we have a problem here. The problem is that there's a huge gap of knowledge, data sparse, low evidence, lack of external validation, lack of commercially available assays for real-time clinical use, so we don't really know what these really represent in our clinical practice, and if they may represent anything in clinical practice now. So definitely what we have now and what we should try to use better is, of course, markers of coagulation, of inflammation, of organ damage. The one in guidelines is D-dimer that works throughout the spectrum, and then, of course, the others. But still, you will imagine that also here we have a huge gap of knowledge. What are we going to do in patients with high biomarkers at higher risk? Is this going to change the way you treat them? So we still have lack of evidence supporting addictive value and implications of our clinical data alone, and we need better study to find this gap and mind this gap. Thanks very much.
Thank you for your talk. Any question from the audience? Yes, Dr. Rainbow.
Thank you, all the panelists. It was a very interesting session about the innovations and some new technologies. I have a lot of questions. We start just with the cider, for instance. My friend Omar Andres, we have also cider, but we are not so confident about the planning and sizing part of this particular software. And also, there is another interesting part that is the follow-up. It has the automatic volume calculation. You have any experience with this follow-up? And the second question is about the confidence about sizing and planning with cider.
Okay, Vicente. Both tools are are from, I think sizing is about 1 or 2 years. We don't have, aside I don't have a lot of experience. And the volume is I think it was available months ago. So about the volume, we don't have experience. We only see that probably in the next years, ciders develop more accuracy of the volume to do the controls of that. We don't have the controls. We don't have test the volume, but I think it's a new tool that cider is important to make more accuracy. And about the sizing, is not like the other software that we use, like Osirix or like Endosize or the others. It's basic. But I think it's enough to do an approximation. Obviously, if you want to do a good planification, you have to do another with another software. I think it's only for approximation. Cider learns every month, and I think sizing probably goes better and better. And this is my opinion for that.
So in conclusion, is software on process. It's not,
yes,
it's not
yes,
finalized.
always is in process. Either every month give you a new tool, and I think this is the interest of the artificial intelligence.
I have another question for Colin. Colin, yes, about robotics, because you are very active since the beginning of the robotics in the vascular field. But I was recently in Saudi Arabia with a very impressive presentation from Lithuania, Sentante Robotic, that is compatible with all different kind of off-the-shelf devices, wires and catheters. That is quite new. And also is you can use 3 simultaneous access with this kind of new robot. So probably we need to be in contact with this new company from Lithuania. Yeah, you know about this company?
This is one of the robotic systems that uses the wires and catheters that you normally use, but as a remote manipulator.
Yeah, for sure. Regular from 2 French up to 8 French size catheter, and 14, 18, and 35.
I mean, it's wonderful, isn't it? You can then do the procedure outside of the operating theatre. You don't have to wear your operating lens. It reduces your radiation time. You can even do the procedure at a completely remote location, and that's been done, which is very impressive. And all these things are very important.
Yeah, absolutely.
But the cost to an individual institution is quite significant for what you're getting, and you will always find if you can do it cheaper and still have the same safety profile, that there will be some resistance to robotics. And I think that if you're going to get a really big rush in enthusiasm for robotics in endovascular surgery and everything else, you need to be able to do more with robotics that you can't do manually, or do it in some way that's clinically much better for the patient. These are my thoughts on it.
Yeah, for sure. Yeah. Another question, if I can, is for the last presenter. The last presenter is about the D-dimer is a good biomarker, but for what? Because what is the clinical implication of that? Is something to add to our algorithm or to our occasion of a decision-making process for intervention, for instance, or not?
No.
So D-dimer is essentially used in the emergency department when you have to decide whether a patient needs a CT scan now or not. This is the most important use, but it's very useful actually, because you have patients at, let's say, moderate probability of having the disease that you want to send home, and not sure whether to scan or not. You cannot scan 100 patients every day. So that's a very good system to help you decide. If you couple it to a good physician, it's better. You do not have to couple it to bad medicine. You have to visit the patient very well and know the history very well. And you should be able to also apply your transthoracic echo and do a focused study. That's the point for D-dimer. What you're going to do D-dimer when the patient is admitted with an acute aortic syndromes? Well, if the patient is going to treatment right away because of urgent conditions, well, nothing changes based on D-dimer. But you know that we have patients that actually are relatively stable with a type B dissection, uncomplicated, that are basically treated with hypotensive, best medical treatment. They may be in medical wards, like in my medical ward, where we have a high intensive care unit. They are not intubated, and we're basically just treating their conditions, their pain, and we're following them with the specialists. Well, these patients then may be discharged from the hospital after 10, 14 days, and then you have to follow up. If you follow up the D-dimer, you may add some information in evaluation of their clinical profile as compared to others. This is my guess.
Thank you. Dr. Álvarez Marcos?
Thank you. I would like to address a question to Dr. Lundberg, actually, about LumiGuide. And probably my concern is going to be shared by a lot of my colleagues in the room. Could you offer some rough figures about how much the installation of the LumiGuide system is about? How is it compatible with different hybrid rooms or even non-hybrid operating suites? And what is the cost per case, the catheter and other negligible material? Thank you.
Yes, thank you for good questions. It should have been on the wish list, lower price. And I think it's hard to compare between countries, but roughly it's, where I come from, it's in the range of 30 to 40% of the full Angiolab without it, which means somewhere 300,000 to 400,000 euro for the engine, for the fixed machines. And then it's about 2 Advanta stent grafts, which is around 2,000 per case. So it's a hard balance. If we use it in regular EVARs, it's a bit expensive. It's perhaps almost half the EVAR stent graft cost. If we don't, which we don't, it's higher per patient, of course, in where we do use it. And then there was another...
That's great information, thank you. And the piece of the equipment that goes in the operating table, is it fixed?
Yeah, it's as I said, it's an add-on to just Philips. And what you hear from them is that they are not at all interested in making it compatible with anyone else, Angiolabs, for perhaps obvious reasons. And it can't move between theaters, if that was one of your questions. It's sitting where it is.
Between Philips theaters, I guess.
It's only for Philips.
Okay, thank you very much. Appreciate it. Thank you.
Any other question from the floor? I would like to ask to Fabian about the artificial intelligence. Although we're talking about artificial intelligence, the accuracy of these studies are not so good. we are talking about an area under the curve of 0.97 as a high. In 30 seconds, please, Fabian, design the perfect study for us, taking into consideration the laws and the ethical issues, and tell us what is the perfect design for develop this technology right now.
I'm not sure I will share with all of you the perfect study because I will do it first. But yes, we have to. I mean, we have to understand that there are several ways to approach AI or to develop studies, depending what you want to do, what do you want to search. Are you in a clinical way, in a research way, academic way? In 30 seconds, it's not possible because I could speak about AI for hours, but no, I really think the key point for vascular surgeon is to design multi-centric studies. So we have to work together to build international consortium, and with international consortium we would be able to avoid all the issue regarding all the legal and ethical framework, all the data protection and all this kind of stuff. And we have to know that, for example, several European projects have been granted, and I'm talking about, maybe some of you know, Vasculate project led by Kaki, or also Net Zero project from recently in Oxford working on non-contrast CT scan. So if we want to design a perfect study, we have to target something, and we have to work all together, merging all the European partners if we want to move forward for the future.
Okay, so yeah, last question from Dr. Alonso.
Thank you. Excellent presentations and very nice session. If you let me, last question for colleague Bignell. Robotics is quite developed for endovascular procedures. However, for open vascular procedures is not the same. Do you think that it should be something that we should forget about it, or there is any place to develop? The largest series with open endovascular robotics comes from Paris, from the Georges Pompidou Hospital, but it's short experience also.
So, with true open surgery, with those big cuts, there are some talking about robotic assistance or robotic tools that can help you in some sort of way. I think that's quite interesting. Probably we're thinking about the robotic Da Vinci system with the robotic laparoscopic robot with the wrists, and there's no doubt that dissection and surgery with that system is very elegant, and it's also much easier, and the learning curves are less, and it's more accurate. They've proven that in clinically in many different conditions. And there are some series, and people are obviously becoming quite adept at it. I don't know, though. Why haven't we, as vascular surgeons, taken that on as an alternative to endovascular? It's probably because it's very difficult and it takes a very long time, and we're very set in our ways. And I think we need to have a serious think about it. If we are going to use open surgery more often because EVA has failed, which I don't think we should necessarily do, then someone needs to take on robotics. But you would criticize it, wouldn't you? Saying that surely you need to develop your endovascular techniques to make them more robust. Sorry. To make them more robust in the long term. That would be the right way to invest your technology and your interest. I didn't give you an answer, but I gave you some thoughts to think over.
So, Thank you all. I think we have a coffee break right now.